So just for a summary of today's program, today's session is on the integration of health and housing to end homelessness. And we're absolutely delighted that we'll hear from Dr. Jim O'Connell from Boston Healthcare for the Homelessness via Zoom. Then we will hear from Jonathan Shapiera, a lived experience advocate, on the ongoing impact of homelessness on his health. And this will be followed by a panel session with some sensational superstars from WA. We've got the CEO of Ruah, Debra Zanella, Dr. Andrew Davies from Homeless Healthcare. Andrew is the CEO Medical Director. Jonathan Shapiro will join the panel. And we're just thrilled to have Professor Lisa Wood from the Institute for Health Research at the University of Notre. And when I reflect on WA, how blessed are we to have an eminent health expert here at a local university. So thank you, Lisa, for joining today. And we've also got the Chief Allied Health Office Senior Policy Officer, Suzi Taylor. So welcome, Suzi. It's great to have someone here from the Allied Health Office. We'll have that panel session and that will be followed by a Q&A. So I now have the great pleasure to introduce Dr. Jim O'Connell from the Boston Healthcare for the Homeless program. And I'd really like to thank Andrew and Lisa for introducing us to Dr. Jim. Dr. O'Connell serves as the president of Boston Healthcare for the Homeless program and is an assistant professor of medicine at the Harvard Medical School. He received his medical degree from Harvard University in 1982 and completed residency in internal medicine at the Massachusetts General Hospital. In 1985, he began full-time clinical work with homeless individuals as the founding physician of the program. He established the nation's first medical respite program in 1985 with 25 beds nested within the Lemuel Shattuck shelter. Working with the MGH Laboratory of Computer Science, Dr. O'Connell designed and implemented the nation's first computerised medical record for a homeless program. Dr. O'Connell served as the National Program Director of the Homeless Families Program of the Robert Wood Johnson Foundation and the US Department of Housing and Urban Development. He is editor of The Healthcare of Homeless Persons, a manual of communicable diseases and common problems in shelters and on the streets. His first book, Stories from the Shadows, Reflections of a Street Doctor, was published in 2015. I really encourage you, if you're interested in this field, to grab a copy of his book. So how good is that? We've got Zoom and we've got this extraordinary skilled physician zooming in from Boston. So I would now like to hand over to Dr. Jim O'Connell. If you could join me in thanking him. Thank you.
Michelle, thank you so much. I hope you can hear me okay. And a couple thoughts just before I started. I wish I could be there with everyone. I had such a fabulous time in Perth, being escorted around by Lisa and by Andrew Davies, Amanda Stafford. I don't know if you're all still there in the audience. I can't see, but I still speak fondly and think fondly of what a wonderful time I had there, and was so impressed by the work that goes on there. So I'm here to learn from you as well, and I'm looking forward to that. I'm going to take a risk and try to share my screen and show you a few slides. If I can go from the start here. So I wanted to, if you'll bear with me for the next 15 to 20 minutes, I just wanted to lay a little groundwork for where we're coming from and why we are all in this together, and we're all in search of solutions, in search of the kind of data that will help us come up with solutions, but mostly in search of how best to care for people who are struggling to survive on the streets, in cars and shelters, wherever, where they don't have the safety of a home. And it creates all sorts of issues for health. And what I was going to start with is I get dragged into this, just so you know. This was not something I had ever planned on doing. And when I was finishing my training in medicine at Mass General, which is one of the hospitals here in Boston, I got recruited to be a doctor in this new program that was just funded for a little bit to try to take care of homeless people, try to integrate the care of homeless people in Boston at the time into the mainstream system. And the foundation that gave that money did a very interesting thing. They said, they'll give the money to the mayor, and our system works by the mayor here, but the mayor has to call together a bunch of homeless people and get from them how they wanted to be served. So everything that I'm going to show you and talk about now came from how homeless people themselves decided they wanted to be served. And this is a picture I love. It's an early picture of what we call our consumer advisory board. It's not a great thing, but these are the homeless people who get together and once every few weeks, and several of them are elected to our board of directors. So one of the fascinating and wonderful parts of my life is that the people that we serve are actually the people that hire and fire us. So this is a group of homeless people, and I always want to start by reminding all of us to make sure we have the voice of homeless people in whatever we're doing. Now, they had some really interesting thoughts. What they were most interested in was looking at healthcare as an issue of justice, social justice, not charity. And what they wanted was continuity of care. And I put that in red because that's what it was all about to them. They were sick of fragmented care. They were sick of going to emergency room, seeing someone, next time they were sick, seeing someone else, never having a regular doctor, nurse, or team to take care of them. So they wanted the same that most of us have in our own lives, which is a healthcare home, somewhere where you go and they know you. And they wanted that continuity of care to go from, very interesting, from shelter and street all the way through to hospital. So we were required from the beginning by the people we were serving to be sure that we did our clinics out where they was convenient for them, in shelters, out on the street, but also to be firmly grounded in the hospital. So when they got sick, and in their minds, when you go into the hospital, that's when you have the most critical illnesses and when you are most in need of the person that knows you best. So they wanted us to be involved in the care. And then I'll skip over the second, but I just wanted to share with you because it's so exciting what you are doing in Perth. Is this is the first time I had seen a request, but they wanted respite care. They wanted they were mad at us physicians and hospitals for sending people back to the shelters of the streets when they were way too sick after an admission, and they really should be going home with a lot of support. But we didn't have that. So they said we had to come up with a respite care program. And this, just to show you, we would have to go out from the hospitals and do clinics in the shelters. And this is our largest shelter in Boston. At the time this picture was taken, it served 800 people each night. It was a first come, first serve shelter. We have about 3,000 to 3,500 shelter beds that are filled each night in Boston. And our job was to go and do clinics, bring doctors and nurses into the clinics in the shelters so that homeless people wouldn't have to come to us. We would go to them. But then they also said, to come up with this respite program, we were handed 25 beds in the corner of a local shelter called the Shattuck Shelter. Our governor at the time was Governor Dukakis, and he was the one that had arranged this. And so without knowing anything about what we were doing, we had to open up 25 beds where we would take care of people coming out of the hospital who are way too sick to be wandering the streets each day or be in the shelters, and might have been able to go home if they had a lot of supports, but none of these folks had homes. And I could spend lots of time talking about what life was like in 1985 and how long you could stay in the hospital versus now when we send people home really quickly. But anyway, this was the first respite program that I know of anyway. We had no model to go on. We just started taking care of people. And I can show you this picture, which is it's grainy and old, but I know the man in the bed in front of us here has bad heart failure. He was on a whole bunch of medications and needed to have the bed nearest to the bathroom. And the man on the left had been in the hospital for a while, and he had lost one of his feet to frostbite and was now being trained to do that. And the man sitting on the bed next to him had very bad lung disease. So those are the kind of things we would take care of, people that just were too fragile or too ill or too infirm to be outside. And about a few weeks after we opened that unit in September of 1985, this man came in. And I say this because it reminds me a little bit of today, but he came in, his kidneys had failed, and he's on what's called ambulatory peritoneal dialysis. And he'd been sent out of the hospital saying, you're okay, you can do this now at home, but he had no home. So he came to us at our respite program, and he was the very first person, this is September of 1985, very first homeless person in Boston to be diagnosed with AIDS. And we realized very quickly after we opened our respite program that people with AIDS, and this was the wave of that epidemic coming our way, were suffering from terrible opportunistic infections, were very fragile, and really needed a substantial amount of care. So that very first respite program we opened in 1985 rapidly became an AIDS and TB program. And when I think back on my career, I remember that within weeks, we had dozens, and within months, hundreds of our homeless folks diagnosed with AIDS. And back then, we had no treatment. And all of them, essentially all of them, we didn't know at the time that a few might survive because of the long-term non-progressives, but all of them had these slow but horrible deaths when they would dwindle, lose weight, get all sorts of infections, and it was really traumatic. And with the coming of the protease inhibitors in 1996, all of that changed. And I think in the course of my career, medical career anyway, these 40 years, that was probably the single most profound change I know of. So we moved, but our respite program, which was in the shelter, really needed to be in a place that could be more therapeutic. So we moved to an old nursing home in the early 90s. And then in 2008, we moved to this building, which is a really nice old building right across from our city hospital called Boston Medical Center. We're right across the street from the emergency room. And now we have about 104 beds of respite care in there upstairs, with 24-hour nursing, doctors, and all the stuff you can imagine. And on the first floor, we have a really busy integrated clinic, medical and mental health clinic. And we have a really bustling pharmacy and a dental clinic. So it's kind of the hub of our services in Boston. And then from there, we have clinics in about 40 shelters around town, as well as a pretty aggressive street outreach team. But in respite care, we learned a couple things. One is that for the many people who are dying, this respite programs can be very, very comforting places for them to do hospice and palliative care and die. It takes an awful lot of the staff, but for people who had really no family left and no place to go, this our respite program, which we now call the Barbara Mcginnis House, after one of the nurses that taught us everything. So if there are any nurses in the audience, most of our program has really been designed, and we are dedicated to the nursing concepts. This is an 87-year-old man dying of a neurological disease with his 37-year-old roommate who's dying of lung cancer. And they were roommates, and they became fast friends during the course of their several weeks in Mcginnis House. And I could tell you lots about that, but just to flag that for things like end-of-life care, respite programs can become very valuable. We also use it as a place where specialty care can come. So this is Ernesto Gonzalez, who's the head of dermatology at Mass General, coming to see several of our patients who would have various rashes. And for those of you taking care of homeless people, I'm sure you are seeing infinite numbers of complicated rashes, and it's so important and so nice to have a dermatologist come by and help us decide what was going on. And then, you know, I thought maybe because I have such a little time, maybe a couple stories would illustrate best what's going on. And this is Greg, who became one of my very favorite patients. And Greg was, you know, pretty feisty, was known on the streets as kind of a rough and tough guy. And it turns out that he has a terrible stutter. When he stutters, people make fun of him. When people make fun of him, then he gets in fights, and then he's always in trouble. But behind the stutter is this really frightened kid. And I met him when he was about 16 years old, and he lived up in the girders of this bridge with his mother and his sister. And this is a main thoroughway near Fenway Park, which is where our park where our Boston Red Sox play, much fabled and cherished in Boston. And he lived with his mother right up there. You can't see him when you're driving by, but this is when we were going by in the van. If you look at those I-beams, I don't know if this projects or not, but these are the I-beams holding up the bridge, and they put boards across the I-beams, and then they crawl up and sleep in there. So in this view right here, there was about 40 people that you cannot see sleeping up inside the rafters, where they're protected from the rain and can't be seen by passersby, which is safe, but they're in a very confined area that has its own real health issues, and they are very exposed to the cold weather. And anyway, you can get a better view there. But Greg, at any point, Greg and you know, when we finally lured him away from here with his mother, we got him to stay. He was sick one day. We got him to stay at a respite program. And by that time, I had been working for a good year to try to just win his trust, and he was very suspicious. But he asked me if I would call his sister, or if he could call his sister. And I pushed the phone to him, and I said, boy, here's the phone. Feel free to do it. And when he pushed the phone back to me, he had to admit that he didn't know how to read or write, and he couldn't read numbers. And as we got more into his story, you know, he grew up in poverty. He had a severe learning disability. And because he lived in the chaos of poverty and in a very blighted area of town, and his mother and sisters were homeless, he never got the services he needed. So he's now, in his 30s and 40s, can't read or write, and really has no skills for surviving. So we finally got him into housing to keep him safe, into low threshold housing. And on the first day that COVID really became prominent in Boston, which was March 7th of 2020, Greg called and said he had a terrible headache, got him to the hospital, and it turned out he had, and now he's all of 45 years old, he had a huge cancer in his head, in his brain, that had come from his lungs. So he had lung cancer metastatic to his brain, and he died that very first day of COVID, not from COVID, but from cancer. And when we look carefully at the mortality statistics among our rough sleepers, our unsheltered adults in Boston, what we found, much to and we looked over a 10-year period, followed many of them, and we found that, not surprising, and all of you already know this, we found that they died at 3 times the rate of the people who were willing to go into shelter. And the people going into shelters in Boston were already dying at 4 times the rate of someone the same age who had a place to live in Boston. So it is very clear and incontrovertible that homelessness comes with its own severe health risks and its premature mortality. So we have been working hard at trying to figure out what can we do, to fix this. And of course, as all of you know, and the theme of this conference is, the platform on which we need to begin to give care is good housing. Now, I don't want to pretend that housing is the final solution, but housing is the thing without housing, you'll never come up with a solution. So here's the reasons that this, one of the intricate things to think about is, I would have guessed when you said, why are these people dying? They live on the streets. We have a very cold climate, it snows a lot. I would have thought, the heat and the cold extremes would have caused a lot of deaths, but virtually all of our deaths were caused by cancer and liver disease and heart disease, a little bit by trauma, and overdoses were just beginning to show up back. This now goes back about 10 years. So we've had to come to grips with an indictment of our own system that people are dying of things that we should be able to treat. We should be able to prevent and treat and at least prolong, if not save their lives. So it became a really important thing to understand what was going on. So we have been for years, as many of you know, trying to figure out, for the people that won't come into us, that are outside, how can you go deliver care that is not only episodic and first aid, but can be primary care or continuity of care or general practice care to people who don't want to come to you, so you have to go to them. This is Dave, one of our fabulous internists and general practitioners on our team, and he's visiting this woman who stays at a local, this is our Amtrak station, our train station in Boston. She's 80 years old, 82 years old, has terrible heart failure, won't go to the hospital, but she's perfectly okay to let Dave and the rest of our team do all of her care right there at the train station, including we can weigh her, get her medications, listen to her heart and lungs, we can talk to her, and she will do almost anything we say as long as we do it there. But to try to talk her to the hospital, no way. So we took care of her heart failure there for about 10 years before she got so frail that she had to go to a nursing home for reasons. This is Jim Bonner, who's our psychiatrist, and he realized that waiting for people to come to something that said the psychiatry office, or the psychiatry department, was for many people impossible. So when he came out with this on our team, he started to realize that a lot of these folks were really happy to sit at a McDonald's or at a coffee shop and have their interview and have their therapy and he would write his medications. And while we once thought privacy would have been the issue, it had not been an issue at all because they just have quiet conversations. So we learned a lot about how we as doctors and healthcare providers had started to think that we had to be in our sacred territory in the clinics and the hospitals in order to do the care we think is good. It turned out we can do an awful lot of fabulous stuff, as you have all learned in Perth, out on the streets and under bridges. We also learned that you can do a lot of preventive care. So this is Jill, who was our physician assistant at the time, giving flu shots out. And almost everybody on the streets, once they knew who we were, would say yes to a flu shot. They absolutely said no until they trusted us. It took about a year. but they said yes. So we can pretty much get everybody their flu shots and everybody their, pneumovaxes and the things that we once thought impossible. And then sort of it all came to roost. This is during the COVID epidemic, I should say pandemic. And this is Jen, one of our physician assistants in the park, giving a vaccination to one of the street folks, one of the guys who lives in that park. And it turns out about 80% of the people living on the streets of Boston were perfectly okay to get their vaccinations. And we realized that they were okay because the person giving the vaccine was somebody they knew and trusted. It wasn't somebody coming from far away. You can actually see the, here, we had to keep, this is in the days we had Moderna, the vaccine, and it, I don't know if you can see it right here. This is the cold pack that we had to drag around to do it. But it was surprising how it was just no big deal to everybody. Now, I can't tell you that it was like that for everybody else, but for the street population who knew us, it was really good. And we had I won't bore you with this, but we had a terrible, 40% of everybody living in the shelters of Boston ended up getting COVID. And we had to open a 500 bed COVID unit basically in the convention center of Boston. So this became the curse of our lives for a long time, but we had to run this unit. And it was for homeless people who had no place to go to isolate or to quarantine, who had COVID. And this was an effort to make sure they didn't have to go to the hospital and fill up the hospitals, which were already way overcrowded. So we learned a lot about that. And then the last thing I want to say before we get into the other stuff, and I don't want to take up too much time, is that we learned that by going out to the community, working closely with our health centers and our, the community, the shelter people and homeless people, we realized that we could only do care that was so good unless we were connected to a hospital where we could have specialty care, access to imaging, etc. So Mass General is one of the 2 hospitals we've stayed close to, and we have a clinic for the street folks every twice a week right inside the hospital. And then we have full access to the hospital, whatever services you need. It's a great clinic. We thought no one would come initially, but there are anywhere from 60 to 120 people, street folks, that will come to the clinic each day, and it's way oversubscribed. I love this picture. If anybody of you can, I don't know what I've just done here, but if you look under here, there's somebody sleeping under here. So it's a pretty hang loose waiting room, and we kind of have to let the behaviors go the way they will, since people coming directly off the street can't shower or anything like that. And so let me end with this last thing. So there's so much more to talk about, and I just was hoping I can just open up the door to what we might discuss. But this is Donna, a woman I took care of for 22 years. She lived on the streets. She lived in a really rough part of town. This is one day when she had beaten up by one of her boyfriends, and had several fractures of her face there. But she really got it together when she got into housing. We were able to get her into housing. She did most of the work herself. And this is her, sort of about 6 months after she got into housing. She has a job. She's driving a car, doing really great. With the one exception being, after about 3 or 4 years, she started to have pain in her right arm when she lifted her shoulder. And so it turned out, after much, we would visit her at home a lot. And it turns out that she had stage 4 lung cancer. She had never been a smoker, stage 4 lung cancer. And this is about 4 years after she got into housing. And what we learned is when our folks get into housing, we still had to go visit them at home because it was very hard for them to get to us. So this is Donna with her boyfriend at her home, and she was very proud of her home. We would see her and take care of her at home. And then just to flag this, we have had a problem with evictions. And it turned out the building she was in was sold, and they were told they had, a month or whatever it is to get out. So Donna has stage 4 lung cancer on chemotherapy, already had radiation, already had some surgery, and her cancer has recurred, and she's kicked out of her house. So this is her back on the street after, her diagnosis. And this picture I look at because several of her old street friends are there with her, including her boyfriend, Andre. And the morning after I took this picture, one of her cancer eroded into one of her blood vessels, and she died. And her boyfriend, who's with her there, Andre, who's another great friend of ours, actually about 4 months after that, took his own life because he just couldn't live without her. So some of the, when you think of the the co-occurring burden, or the burden of co-occurring medical and psychiatric or behavioral health and substance use disorders colliding in people who have been, really courageously struggling against all odds. They are desperate not only for housing, but for really coordinated, integrated healthcare that really is convenient for them and comes to them. And I would go back to that original principle that most of what we can do, we got to do because we could stick with them over time. This is about continuity of care, which all of you know, and I've seen done so perfectly in Perth, where it's, you embrace people to take care of them, and you stand with them through the good part and through the bad part. And if you can, as we like to say, you stand with them in the darkness and in the light. But anyway, let me stop there because my time is up, and I just look forward to hearing more about, let me stop sharing if I can learn how to do that quickly. I hope I did that. But just to finish by saying thank you so much. It's such an honor to be here, and I wish you were not late at night here in Boston. I wish I were there with you early in the morning tomorrow. Okay, but thanks so much.
Thank you so much, Jim. What an amazing presentation. Just the humanity that came through. I mean, you're a superstar doctor, and the focus on the people. I just want to cry. It was just extraordinary. We're really blessed that Jim, it's very late in Boston, but he's going to stay on for the panel session. So there'll be an opportunity to ask some questions if you've got things that you'd like to ask him. So can you join me again? I think that was an extraordinary, really extraordinary presentation. I'd now like to introduce Jonathan Shapiera. Jonathan is a former project manager who ended up becoming homeless after losing his job abruptly in Darwin and not being able to pay the rent. After nearly 3 years living on the streets in a car, Jonathan is now living with the consequences of living rough. He's the Executive Director of the WA Council of Lived Experience and an absolutely tireless advocate to end homelessness. Jonathan's one of the fabulous people who keeps us all honest at Shelter WA. And please join with me in welcoming Jonathan to the stage. And Jonathan, I'm going to be a timekeeper. I'm going to keep you honest.
Good morning, everyone. Sarah's only given me 15 minutes because she knows I can talk the fleas off a dog's hind leg. So I've got to set this and see how it goes. What I'm going to do this morning, there we go, that's counting down, that's good, is really follow on from what Dr. Jim has said, but mostly on the West Australian side as far as concerned. Please understand that as a lived experience, there are particular triggers that do run formally with those of us who choose to stand up and speak. And those triggers can come from almost anywhere. I'm actually now recalling what Dr. Jim has just said. That's Boston. The same thing's happening here on Perth streets. But you don't know that, you don't see that, we do. We were there, we were part of the actual phenomenon that actually went on. In 2014, when I got off the streets, my son and I had been on there for pretty close to 3 years, 18 months in Darwin and 14 months here in Rockingham, living in a car. And triggers for me, the rain last night. You heard it come down? Yeah. Imagine being in a car with the rain coming down and absolutely just pounding on you. And your son, your child, is somewhere in the car sleeping. But anyway, we'll get on to all that a bit later on. What I want to do this morning with the time that I've got is to talk about, it's not just talking about the story itself of being homeless, but what happens afterwards. Have any of you really considered exactly what happens to the people that you take care of afterwards? One of the main consequences that we're looking at as far as a lot of this is concerned, and I've been challenging this whole aspect of health and homelessness for nearly 4 to 5 years, when I realised that myself, I was having problems, and I'll get into that again later. But as far as the actual post-homeless syndrome is concerned, for whatever you want to call it, after you've actually got off the streets, things start to break down. The best way that I could look at actually suggesting to it is that while you're actually homeless and you're living on the streets itself, the body goes into fight and flight. right? You'd understand all that from what you've probably been through as far as some trauma is concerned with other parts of your life. But you go into fight and flight and the body builds a cocoon. So it actually wraps itself around you and it protects you. But once you actually get off the street and you actually find somewhere to go and live, the cocoon breaks down. But Dr. Jim went through and said cancer was one of the biggest things that they saw as far as after homeless is concerned, post-homelessness. Okay, that's a bit better. You can probably hear me better if I raise that. So as far as what we're talking about in WA, I've got 4 subjects I want to quickly go through and talk about with the idea of what actually happened to them post-homeless. First guy that I want to talk about is Mervyn York. Morty, we used to call him. He was part of our particular group that was homeless here in Rockingham. If you know where the wheat silo is, the big blue thing that's on the foreshore there, we slept in one of the car parks, just up from there. And as you look around and raise it, we can always see that big blue thing. So again, for me, the big blue thing is a bit of a trigger because it brings me back to remembering exactly what happened. Mental health is another major issue we'll talk about. But Morty, as we called him, he came with me November the 11th, 2014, as we went to the Federal Senate to actually talk about, we were the first group to actually present to the Federal Senate about homelessness itself. And we actually sat in front of the senators and talked about a lot of things. Health was one of the things that we discussed. That's 8 years ago. And we're only just really getting into the whole aspect of health and homelessness now. Have a good think about that. But the point being is the fact that Merv walked on 2 legs with me up to the Federal Senate, presented his story as an Indigenous man, 67, 68 he was back then. 18 months after getting off the street, his support was 12 months. 6 months later, they cut off one of his legs. A year later, they cut off his second leg. Morty was a diabetic, just like myself. So diabetes is very, very prominent throughout the actual street population, but nobody's looking at it. Nobody's doing anything about it. And nobody's really getting into the voyage of actually understanding what happens as a diabetic. Now, think of it quite plainly. When you're in the summer, I inject myself with insulin, and I did not know that my insulin kit that I had to inject myself with during the summer months was absolutely useless because of the fact that it goes off. Once you've got heat on the insulin, the whole chemical synopsis of what it is breaks down so badly that you're injecting nothing but water into your veins, into your actual body itself. So there's nothing there that is of any determination that's going to protect you as far as that's concerned. So I had 3 years. You live in Darwin, you've got 32 degrees through the night, 34 degrees through the day. So 18 months there on the street with insulin in the thing, it was useless, absolutely useless, excuse me. So when I got down here to Rockingham, the same thing happened. So we had temperatures down here in 2013 thereof when I was down, and the summer months, I was still injecting myself. I did not know that the amount of problems that would be created because of the fact that I was not looking after my diabetes properly. We'll get on to that. Now, Morty, okay, lost his 2 legs purely from the idea of diabetes, but you got to think it's more than likely because of being homeless. The diabetes is one thing that affects the people, but then being homeless on top of that, how do they control it? How do they do what's going? Certainly there is a necessity, an absolute necessity to look at those people on the street that are diabetics, to actually help them, because the afterlife is so bad, you don't know what to go. As far as the second group of people that I wanted to talk about, I'll read something. This is George and Lizzy. Now, Lizzy's a long-term homeless person, lives in Rockingham. She's been through many different aspects as far as her life is concerned. Lovely lass, very intelligent, and I'll give you a quick little read of what she wrote we got together as a lived experience group a little while ago, and in one of the documents that has been produced by Shelter WA, we all had that opportunity to say things. And I'll let you read what Lizzy wrote. Living on the streets affects all aspects of your life. It's one thing to crash on a mate's couch, but rough sleeping takes a major toll on your mental health, spiritual and physical health. So many of my friends have attempted suicide, and unfortunately, many have succeeded. Yeah, a couple of guys that I knew with Lizzy, Laurie was one that was in the paper, in West Australian paper. He was one that took his life while actually on the streets. I want to talk about something to do with suicide again a bit later too, if I can. So George and Lizzy had major problems as far as their health was concerned once they actually got off the street. I won't go into great detail. George had a major problem with one of his hands. He went through operations quite sustainably to actually fix the fact that he could even close and open his hand. Predominantly, Lizzy had problems with her neck, her back, and everything else, because the fact simply they slept in a tent. Now, they slept there for quite a while. Of course, you know, sleeping in a tent around here with the councils, they come through with a bulldozer and they absolutely mow your tents down. Doesn't matter where you are, who you are. You bunch of bastards aren't supposed to be here. Get out. But it's the only place that they had. So what we go through from there is the next subject, which I hate talking about, is myself. So I got off the streets 2014. A lot of help from political influences and a few other people as well. And I went through with the Salvation Army, who actually helped us walk through the whole post-homeless scenario. But in dealing with my support worker from the Salvation Army, you know, I'd yell out to my son, Nick, quick, Rachel's coming, clean up the house, clean up the house. Because I was scared shitless, the fact that I was going to get kicked out. I didn't want to go back to the streets. The mental health trauma that goes with you in regards to a lot of that is so, it's mind-blowing. And when they stopped the actual personal visits, then Rachel took to phone calls. So she'd ring me up and she said, how are you? Oh yeah, look, I'm brilliant. Absolutely no problem at all. I was crying 5 days after that. Absolutely down in the dumps in the whole problem. I haven't worked for nearly 10 years. And I come from private school background, university degree, Royal Australian Navy. And it took a hell of a lot just to actually look at the idea of getting up and talking about the problems that we go through as far as life is concerned. You call us lived experience. We're more than lived experience. We are people as well, but there's a difference in the cycle as to how we're treated, and that needs to change. With me, as far as my life was concerned, post-homeless, I got off the streets in 2014. 2015, they found that I had the potential as cancer is concerned, cancer of the esophagus. Esophageal cancer is not something you deal with. It's a case of you're either going to drop dead and die from it, or they've got to do something. So they jumped in, they ripped out my esophagus, then they cut my stomach open, took half it away, tubed my stomach right up the middle of my chest and stuck it to the top of my throat. I've got no esophagus anymore, but I'm alive. Okay, 14 hours on the table to actually perform what's called an Ivor Lewis. I've learned more about that today as far as a lot of medical procedures are concerned than I had before. 2016, they found that I had a spinal cord deficiency. My spinal cord was actually crushed. Don't ask me how, except the fact that sleeping rough is more than likely the actual cause itself. So I had a major crush in one area and a secondary crush in another. Okay, so another operation. If I didn't have that, I'd be a paraplegic. So they opened my neck up. 23 staples that I had when I got off the operation, 4 hours on the table for surgically being administered. The circumstances that relate to that are now enduring as far as post-homeless concerned, because they had to muck around with my spinal cord. I've got a carer now that actually helps look after me. My diabetes is absolutely off the charts with a lot of the stuff. if you're going to look at the whole perspective as far as trying to get on day to day, because of the nerve damage that's been caused, my diabetes, when you go low with your sugar levels, I don't feel it. It just drops and that's it. Then I drop. I've had 6 diabetic comas in the last 2 years. 6. I'm waiting at the moment for particular devices that can be fitted on me that will actually make an alarm when your sugar levels drop below a certain point. The last time I had a coma was actually in Rockingham Hospital, April the 7th. I had a heart attack. Decided with my son at 2 o'clock on a Monday morning, I better go to the hospital, Nick. It's a case of, well, do you really need to or not? No, let's stay home and have a coffee. No, Dad, you're going to the hospital now. And it's lucky you did, because they said I'd had a heart attack. Now, 5 days later, I had open heart surgery. They ripped open my chest, ripped open my arm from the wrist to the elbow, and ripped open my right leg from inside thigh down to the ankle to pull out the tubes, vessels, whatever you want to call them, to replace. I had 4 vessels replaced. I'm not a smoker, not a drinker, but diabetes caused the whole basis of the problem with that. What caused the problem to do with the diabetes? Being homeless. How do you not turn around and look at the complications of the medical side that is going to affect the people on the street? We have been working tirelessly to look at the idea as a group, and a lot of faces that are here have known me for the last 8 years as I've been working with this. But to actually understand a lot of the post-homeless problems that occur, you've got to come and see a lived experience. You've got to look at the idea of understanding it's not just 4 walls and a roof. It's got to be a lot more than that. The contracts that you guys actually have as far as post-homeless support is concerned is 12 months. That's it. No more money. You're on your way. You're on your own. Off you go. 6 months later, the body breaks down. 7 months later, they're in hospital. Look at what Dr. Jim just put on the board for Boston. That's still happening here in Perth, but we're not highlighting it enough. I've been screaming about this for the last 4 years. And reference in regards to a lot of this does come down for the fact that we're not being listened to. The lived experience need the actual aspect to really talk to you guys in a way that you will understand exactly what it is to be on the streets, what actually happens. I'm so pleased to hear the fact that what I'm talking about, I've been trialling, is actually going on in Boston, and they're doing research over there about the whole thing. I didn't even know. But they're dying from cancer. Now she gives me 1 minute, gee whiz. Okay. In the minute that I've got as far as the wrap up is concerned, let me just talk quickly about the final subject, my son. 16 he was when he was homeless with me. A year and a half ago, he was diagnosed with keratoconus. Keratoconus is malformation of the eyeballs. And in going through that and getting it, it's because of the fact that you don't have the necessary proteins, conditions, or whatever while you're actually growing up. Who's a parent? Who understands the fact that your son is going blind and it might just be your fault? Let me just wrap it up quickly with one quick saying. 4 walls and a roof don't end homelessness. It's a matter of actually getting involved with those that understand, those that know, and those that really want to contribute. Not all of us can stand up here that have been there. Triggers are immense. I don't have time to talk about the mental health and the others, but thank you very much indeed for listening.
Can you thank me again? Sorry, thank Jonathan again. It's extraordinary. Just the way that Jonathan can share his story just keeps it real. And similar to Dr. Jim, just the humanity that comes out is so important, because we can talk about statistics and numbers, but it brings it down to people, and having people at the heart of everything we do is so important if we're going to crack this nut and end homelessness. So thank you, Jonathan. I would now like to invite our superstar panellists from WA to the stage to reflect on the integration of homelessness and health services here in WA. So I'd like to invite the CEO of Ruah, Debra Zanella. Can we have a big Oscars round of applause for Debra? The Homeless Healthcare CEO, Medical Director, Dr. Andrew Davies. Round of applause for Dr. Andrew. We've got Jonathan already on the stage. Superstar Professor Lisa Wood from the Institute for Health Research, University of Notre Dame. And Lisa's research keeps it extraordinarily real. Round of applause for Lisa. And our final panellist, and we do need another chair. So she will be on the couch, is the chief, from the Chief Allied Health Office, Senior Policy Officer, Suzi Taylor. So a round of applause for our government colleague. And as I mentioned, Dr. Jim is staying online. So Royston, I don't know if we can bring him back up to the screen. Beautiful. And it is late in Boston. So again, thank you, Jim. So what I'd like to do, I'll just swing around if that's okay, Royston, so I can see this fantastic panel, is just invite each panellist to reflect for a couple of minutes on the integration of homelessness and health services from their perspective, what is working well and what could be done better. So if we could just have your reflections on that, and then we'll go into a Q&A. So Suzi, are you happy to start?
Just testing.
Yep,
or working. So integration of health and housing. I work for the Chief Allied Health Office, and we have a big focus on stakeholder engagement and evidence-based practice. We also look at health service delivery across funding and policy directions. I think cross-agency collaboration is very important, and I think that so we're doing some of that quite well. I think that we could do more of that between the health and housing sectors, and particularly with government. I think that workforce development is really important, and also the use of data and information to inform our decisions.
Thanks, Suzi. So if you could pass on to Jonathan. 2 minutes, Mr. Shapiro.
Yeah, you know I can talk. I'll keep going. If I put a microphone in my hand, and I'll just sit here and yabble on. Look, as far as the health side is concerned, you've heard what I've had to say with a lot of it, but integration-wise, when I was on the street, 2014 when I got off, so 2013, 2014, I was here in WA. The major problem we had back then is that nothing was happening. It took a lot of us to actually get involved, to actually get it going. Now there are things happening, I've got to say, and I'm pleased that you guys are actually doing something as far as the health integration is concerned. My one comment that I really must look at as far as health is concerned is to look seriously at the idea as far as short-term accommodation is concerned. It's got to be done. As we were going through the idea, and as I spoke very briefly about the rain coming down, now we would have loved the idea to have a parkway or something rather with the bed thrown out. Lying flat on a bed is a major necessity as far as your health is concerned. That's come down now to being an underestimated value with a lot of the people. For those that actually run the shelters, I'm going to be quick. For those that actually run the shelters, you look at the long-termers as they come off the street. You go and see their bed in the first night, it's not been slept in. They're slept on the floor. And that's one of the things that needs to do. If we can give them a short-term aspect that they actually only go to. The 2 points that I have tried to raise is bed down and sleep bus, and try and get them here to WA. Short-term aspects, then take them through the long-term and give them the bricks and mortar. But if we do not give them a place to sleep, their health is going to deteriorate very rapidly over the years to come. Thank you.
Thanks, Jonathan.
I think my experience in the 50 Lives, 50 Homes, and particularly working with homeless healthcare in those very early days, and the story of the diabetes, I've Lisa, you'll recall one of the case studies in which the person talked about the fact that they finally had somewhere to put their insulin in the fridge because they had a fridge in a house. I just don't think we can't disconnect. I think the issue of integration, which is like the last thing to fall in the universe, is still really hard. And I think we have pockets of excellence, and the work that gets done with homeless healthcare, I think, are exemplars of that. But if I stand back and think about COVID, I think the difficulty we still struggle is that systems are large and they articulate really, really poorly. And health is an enormous system that doesn't see itself necessarily connected to community services or primary health in the same way that we might see ourselves integrated within the community services sector. And that's not a criticism of health, but it is a criticism of the way we establish systems and assume that the system has the answer as opposed to the individuals within the system who need to drive that change. And the real example for me was during COVID, when we were dealing with health and the issue of asking our clients to line up for PCR testing or to go home and isolate if they were positive. So the assumptions, the blind assumptions that people bring into the systems that articulate, I think, are the things that we have to break down.
Thanks, Debra. Dr. Davies.
I think it's very easy to be negative. I started working in this space in 2004 and have seen an enormous amount of change since I started. Things did not articulate at all back in 2004. And there's a lot of good examples now in Perth of how we can work together. Interagency collaboration is always difficult. I think it's the #1 stress in my life. But there's great examples just within our organisation of us not only working with Ruah, with the After Hours Support Service, we work with them in doing inreach into Royal Perth Hospital. We're also doing street outreach with Uniting WA. And by working together with the homelessness services, we are able to deal with not only the health issues, but the actual primary driver of the poor health in the first place.
Thanks. Over to you, Lisa.
Last but not least, I think as Deb touched on and Jim shared as well, fundamentally, housing is a health solution. You know, there's some initiatives in the US that even talk about, you know, prescribing housing. And as we've seen in 50 Lives and in our research with homeless healthcare, you really can't separate the two. All our data, no matter which way we kind of chop it up and look at it, and what we see in the lived experience accounts is that the longer people are on the street, the more their health deteriorates. And Jonathan has shared that this morning. But equally, I think there's that amazing book about The Body Keeps the Score in terms of trauma and the legacy that leaves on people's health. And it's the same for homelessness. The body keeps the score. And so I think it's not, you know, so we've got to get people housed. It has to be the right kind of housing, you know, where they've got access to social support, health services, etc. And then that continuity of care. And really, I think it would be great if we were in a world where mainstream services were super savvy about what it's like to have been homeless and responsive to that. But our health system is just, you know, struggling to deliver its services the best it can at the moment. And I think, so we do need that specialist care. And I think those kind of wraparound supports, and as Jonathan talked about, they have to continue. So, you know, the programs where it stops at 12 months or after hours services where, you know, it's pulled back. I think that the reality is that exiting homelessness is not linear. People often fall back into it, or they're at risk of falling back into it. Their health is at risk of deteriorating. And so that kind of integration between the housing and the health has to continue. Really, it's a societal obligation to see that through for the rest of people's lives.
Thanks, Lisa. And Jim, I might just ask you that question. So from your perspective, in terms of homelessness and health services, what's working well in your part of the world?
First of all, it's actually great to see old friends sitting up there. Sure wish I was there with you. But I think you have all from my perspective, hit the crux of what is the problem ahead of us. So we know we absolutely need housing. We need housing in safe places that's got all the right stuff, but we also have to respect exactly what Jonathan brings out so well, is that many folks have lived through hell, and once they get into housing, that hell just doesn't go away because of four walls. And so what kind of supports people need and how we can gear those up, I think are going to be really critical. I would share with you one thing that is frustrating us, because we don't really have the answers. We've, in many ways, we've got, in Boston, we have a pretty good integrated healthcare system, but not very much available housing. And other cities I know has much more available housing, but not an integrated health system. So finding out how to articulate, I guess, Deb, as you had said, is the way to do it, that these systems need to be integrated if we're going to help the thing. Final thing I would say is that I think we're learning. So as you know, we've had now the first of our rough sleepers starting getting housed in low threshold housing back in 2004, after many had been on the streets for 20 years. And now that we're almost 20 years into this experience of what happens after housing, I think we really are all desperate to get good data on what happens after 5 years, after 10 years, after 15 years, so that we can learn to fashion the services and maybe the types of housing we need, especially as the population gets older. So there's lots ahead, but I don't in any way want to pretend we have any answers. I think what I have just heard now is as profound as I've heard in a long time.
Thanks, Jim. And the evidence is really important, and we're thrilled that Professor Wood has provided some data. So that's on your chairs there. Following the evidence is critical if we're going to have the services meet the need. And for people on Zoom, we'll certainly make sure you get a copy of that data. So I now have the pleasure of asking some questions of the panelists, and then what we'll do is we'll open it up to the floor and also to people on Zoom. And so I'd like to ask you the first question, Andrew, if that's okay. So Homeless Healthcare, along with Ruah and Uniting WA, is running WA's first medical respite centre. Who's heard about that? Hands up if you've heard about the medical respite centre. Great. It's about not very many people, so you're going to hear about it now. That opened in last October. So Andrew, it would be fantastic if you could tell us about the services provided at the centre and what change this has already brought to people experiencing homelessness with chronic health issues. Thank you.
Wow, how long do I have? Okay, 1 minute, great.
No, you've got more than a minute. But please, panellists, be aware we can switch you off any time. So Jonathan, you can talk for as long as you like, but no one will hear you. Okay. So Andrew, please.
Sure.
Yeah.
So back in 2011, I visited Boston, and that's when I first met Jim. And I also got to see their respite centre. And ever since then, I have thought that it would be a fantastic idea for us to have in Perth. There was a few things about their respite centre that I thought could be done better. One of which is that their respite centre looks like a hospital, and I hate hospitals. Anyway, we were lucky enough to get funding through East Metro Health Service last year, where we were able to open a 20-bed facility. The easiest way to explain it is a place where people can go when they're too sick for the streets, but not sick enough for hospital. So it's both about pre-hospital care and also about post-hospital care. And we are doing it in Palmerston Street, I can remember. It is a very homely, home-like place. And I think that is one of the biggest therapeutic things that we've stumbled on. There's an enormous number of good stories that we've seen. It's basically excelled any of my expectations. I think it's one of the things that has been important to me is that we're able to show the data that we are actually making a difference, that working with the homelessness services, we are able to get people into permanent housing and keep them supported there afterwards. And it's great that Lisa Wood is getting to do all the evaluation of the service. So I'll be able to tell you much more about the positive side of it next year.
Thanks, Andrew. So we've heard from Jim that these sorts of facilities are really critical and they're part of a suite of health services that are needed. You've set up the service. In terms of the security, is the funding secured into the future, or is this a pilot?
So it's currently a pilot, 2-year pilot. So we are leaning very heavily on Lisa to show how effective it is, so the government will continue so that we have ongoing funding.
Yep, so we've got a pilot facility based on a fabulous model that we know that works in Boston, and we just need to get the new evidence to make sure that we get the secured funding.
Correct.
Okay, good. I've summed that up well. Okay, so Andrew, you've mentioned the work that Lisa does. So Lisa, the evidence you've been collecting is so critical to our sector, not just in the health space, but just in general, the evaluations. I suppose marshalling that independent argument to government to say this works, so feel confident investing in it, or maybe this doesn't work, it needs to be optimised. So we're just such a fan and blessed that you're in WA. So what do you see as the biggest gap in the research and the evidence? And if money weren't a problem, if we could wave that magic wand, what research would you like to see progressed in terms of homelessness, health and housing?
Well, I hope some funders are listening. Yeah, the magic wand, that'd be great. Yeah, I think for people who know me and our small team's work is that we don't do any research just for the sake of it. And Andrew hates hospitals, and I hate the notion that academics just sit in an ivory tower doing stuff just to publish papers. So we actually do a lot more applied research and don't really write as many papers as I probably should. So I think for me, the research gaps are around further, for me, that you can't really separate research gaps for me from what the service gaps are, the needs of people. So very much in the way that Andrew identified the need for post-hospital care for people. You know, that's an area or a couple of years ago, Homeless Healthcare, we helped them get a grant to pilot a dual diagnosis outreach service for people that have both mental health and drug and alcohol issues on the street. So I think very much we're always looking at what are the gaps where people have needs that aren't being met. And so I guess if my top 4 kind of wish list, if anyone's listening, one is that I have been working with Homeless Healthcare to try and get some funding around the needs of pregnant women on the street, and looking at the which is a big gap area. There was at least 9 pregnant women that Homeless Healthcare has supported over the last 18 months, and lots of issues and fear around hospitals and your baby being removed. So that's something, and I think right through to, so that really that kind of across the life course thing about, you know, because otherwise babies born into homelessness, and particularly intergenerational homelessness, you know, that's a huge barrier right from the outset. I think you mentioned about the MRC being a pilot, and Amanda Stafford, our colleague, talks about the graveyard of pilot projects in government. I won't look at you, Suzi. And so that does worry me. I think a lot of our things that we do with, whether it's with the homeless sector or with homeless healthcare, you know, like the dual diagnosis, we had a great report, it showed results, was loved by the sector. It was a 1-year pilot. You know, that's it. I mean, I would really hate to think that that might happen to the Medical Respite Centre. You know, there's other things that homeless healthcare and services get funded to do to try it. And so I think that's one of the biggest frustrations for research is how can we play a role in ensuring that if there's evidence that something is working, to keep that going. And I guess that's the continual challenge for me, is trying to find creative ways to creative but factual ways to show what is working, and to try and, I guess, cut through the tendency of you know, big government or big systems to just keep doing things the way that we've always done them.
Yeah, thanks, Lisa. And for those that were able to attend the session yesterday, we had Paul Flashow talk about some research that I think was done a few years ago. And I think what drives me nuts is we have pilots, but if you look at the economics in terms of the costs and benefits and investing in housing, really good health services and homelessness services, the cost of people cycling in and out of hospitals, emergency department, mental health facilities, back onto the streets, it is much more cost effective for somebody to be put in a home and have the services that they require, as opposed to that ongoing iterative healthcare cost. The economics stack up. For some reason, the CBAs don't seem to translate from the pilots into the government budgets, and it's insane because it is much cheaper to look after people. So net of the right thing to do. And as Jim said, you know, we're talking about humanity and people. The economics are crystal clear where the money should go.
Can I just add one comment to what you just said? Only because I think that really comes back to that first question you posed to all of us about integration. So there's a notion of what some people call the wrong pocket problem. So I think we've done great work, Paul, other people, to show that, you know, you save the health system money when people are housed, and that came out really clearly in the 50 Lives evaluation and in the work we've done with homeless healthcare. But then people in housing will say, well, that's not saving us money because we've got to spend more money on housing. And I think this is a challenge and why we need that whole of government response, because otherwise we can do stats till we're blue in the face to say that this will save the health system money. I see the same thing in terms of one of my other wish list research things is around the justice system and people either going into prison who've been homeless and then coming out of prison and being homeless again, and just that cycle. But again, you have the same challenge where justice is, you know, trying to save money to spend on another prison, and they're not, that's a different pocket to where we might be saying the money needs to be spent to address homelessness. So I think there's lots of rhetoric around about whole of government responses and systems thinking, but I'm not sure that we're quite seeing it yet.
Thanks. So I might pass over to Debra to reflect on that, and then I might ask Jim if he could talk about the American experience before I come to Suzi and Jonathan.
Yeah, and you can skip my other question. Well, because I think this is a really important conversation, because I think we have a lot of evidence. And I don't think the question is more evidence, although it's always important to evaluate. I think it is a question of political will, and that is much more two things. One is political will, and second, I think there is no mechanism currently where we pilot things and have good evidence, a seamless system for that coming into a commissioning process, and a commissioning process that doesn't then divide the sector or distort the evidence. So I think as a sector, we've got to just be a little bit mindful that we don't over evidence, because, you know, Lisa, I think you would say, and Andrew, that the evidence out of the very early 50-50 was pretty compelling evidence. And whenever you spoke to individual politicians or policymakers, they were pretty convinced. But the mechanisms that allow us to interpret that back into a commissioning process that actually causes collaboration is absent. It's a little bit like when we have philanthropic funded initiatives that provide fantastic evidence, of which 50 Lives was. There's no mechanism for that to be mainstreamed without it getting distorted because of the other agendas. I think it's a political issue and a political narrative that we are still to nail, and that we don't have all the levers for. So I think it's our next big thing as a sector that we actually have to master. Otherwise, you know, we will have more evidence than Star Trek and still not be enough.
Well, Star Trek, you can never have too much evidence about how great it is.
Yeah.
But Jim, I'm just wondering, in Boston or the US, have you cracked this nut in terms of having some compelling evidence that enables sustainable funding of the services that work?
No, we have not cracked it, but I can.
Wrong answer.
You know, it's interesting. A reflection I have going back to what the discussion is all about now is something that's been haunting us, that when you try to take care of people who have experienced homelessness for years and are waiting for housing, and in our, for example, just think in LA, Los Angeles County, we have 60,000 people living on the streets of LA. It's going to take decades before we get enough housing to just house those people. So one of the struggles that is happening, and this is emblematic of it, how do you provide the care that those folks need, your respite care, you're reaching out with health, etc. How do you provide that care while you're also trying to get the housing up to scale in a way that makes sense, housing with support? So what I've come to grips with is that if this is a big both and, it's not an either or, that we need both. And one of the struggles we're having, and I could just, let me tell you something where I whine as a doctor, like we have people living on the streets of Boston desperately in need of therapy and better behavioral health services and more specialty care. But people will say, well, we don't want to put the money into their care, we want to put the money into housing. And we do need to put that money into housing, but if it comes at the expense of caring of people, they're putting us into that box that it drives me crazy. It feels like they've taken control of our narrative, and our narrative should be, we have to get the housing up to scale. We need the services. And frankly, I don't care if it saves money or not. These are people who are, they're struggling and need to survive, and they deserve the dignity of good care. And if we save money, great. But if we don't, we still need the political and social will to fix this. And I don't see that coming. We've had the same problem you have. You can show great results from a small pilot, but does that then translate into a national policy? Not usually. So I think we've got to work on both of those. And I think this difference between how do you address the population as a whole versus the individuals that are stuck reminds me of disaster medicine. When you have an earthquake in a place, you have to take care of the people struck by the earthquake, but the real problem is how do you build the infrastructure to make sure this doesn't happen again? So I think we all need to band together. And finally, what I would say is, in our country, we have a bunch of small studies that are kind of fabulous, people working hard, but our government does not invest in big studies of homelessness. So we don't have sweeping randomized controlled trials the way we would do with any other thing. We only have small pre and post kind of studies, which are the only things any of us can do. We usually do it with a shoestring budget and do it mostly at night and weekends with a lot of people. And those results are nice, but they don't carry the same weight as big studies. So we're in this funny, kind of awkward thing where we've studied this like crazy. We all know what the answers are, but nobody, at least in the US, there are very few researchers who can be sustained studying homelessness by our federal dollars. My wife, I'll give you an example. My wife, who Andrew knows well, finished her doctorate in public health at Harvard School of Public Health. There's not one single faculty member at that school who is studying homelessness. And I would argue that homelessness is one of our most pressing public health problems. It's not because they don't want to, it's because our government doesn't fund it. But you'll find lots of people studying many other things that I would consider relatively minor social problems right now. Anyway, enough, I'm whining here, but that's where I would come down. I think we have a lot, a forum to discuss things like this, just as you were doing, is critically needed everywhere, I think, and particularly in our country.
Thanks, Jim. So it's great to have Suzi here from the Office of the Chief, no, I always get this wrong, the Chief Allied Health Officer Office. Did I get that wrong? Yes.
You can call it CAHO.
I'll call it CAHO. So thank you. So Suzi, how do you see the activities of your office and the new homeless health action plan that you're developing? How do you see that aligning with the WA homelessness strategy, given the importance of integration of homelessness and health that we've heard today?
One example I want to provide is aligned to the no wrong door policy, the no wrong door principle. And I think that CAHO is definitely looking at strengthening the workforce in mainstream hospital systems with a better use of the no fixed address. So when that's flagged in the system, what do we do with that information? Where does it go? And does WA Health know where to refer people when they come, people who are experiencing homelessness when they come into the system? The other, and low barrier access is, I think, incredibly important, which is another one of the principles. We are supporting a pilot, the Discharge Facilitation Fund, and we also commission Professor Lisa Wood to evaluate that for us. But what the Hospital Discharge Facilitation Fund aims to do is to reduce discharge back to the streets and discharge back to homelessness. And there's a number of hospitals involved across Western Australia. I think there's about 7. and they're provided with brokerage funds. It's largely used for short-term accommodation, but I think if we can raise awareness about how to better identify and how to manage the complexities of people who are homelessness, and that would be a really great place to start.
Thanks, Suzi. So we might open it up to the floor for questions. So Royston, do we have any questions on Zoom that maybe you or Sarah could ask?
Thank you, Michelle. We just have a comment from Michael Pugh so far, so really encouraging people on Zoom to send their questions through. Michael says that he couldn't agree more with Deb, recommissioning of evidence-based approaches. In health, we have a further problem of multiple funders, including federal government, WAFA, state government, area health services, etc. Specialist service responses fully evaluated and proven, such as St. Pat's Oral Health Clinic, are built up but left unsustainable and unable to meet demand, as no funder will take responsibility for funding them. So that's a comment if the panelists would like to respond.
Thanks, Sarah. And for people that don't know Michael Pugh, he's the CEO of St Patrick's in Fremantle, and just want to give a shout out to St Pat's with this horrific weather. They've opened the shelter doors at night so people experiencing homelessness can be sheltered from the storm. So that's a huge, huge thing for St Pat's to do. So congratulations, Michael. I hope the last 2 nights have gone really well down in Fremantle. But would any of the panelists like to reflect on Michael Pugh's comments?
I'm slightly reluctant to say that we need another kind of guideline or document, but there is in the UK, which is doing up there with Jim in terms of amazing work around homelessness, there is commissioning guidance around commissioning services relating to homelessness and at that intersection of homelessness and health, which I have been forensically reading for something that I'm doing for Andrew and trying to distill it into half a page. But I guess that's an example of like it is possible. Obviously, a guideline is only as good as it gets used, but I think there are places that are at least having a go at saying this is a highly vulnerable, high need population. And if you are going to fund or deliver services in this space, this is best practice. And this is how you do it. So that's just one kind of comment back.
Thanks. Debra, did you want to make a reflection?
Well, I think it goes to the heart of what I was saying before. And I think we're not sophisticated in our commissioning processes. And whilst we talk about co-commissioning, I think the co-commissioning is often an agenda that doesn't actually meet the agenda of the need that's presenting. And I think that's part of the difficulty. So whilst I'm also not in support of further guidelines, I think we just have to get more sophisticated and more collaborative in the way we commission. It is the holy grail, but what I've seen, and to Michael's point, on the whole, we don't do it very well, and it causes far more destruction and an unpicking of things that have worked than actually providing something other. So,
no, sorry, you need the microphone, Lisa, for our Zoom colleagues. Oh no, okay, Andrew.
I'm not normally this pushy. No, I'm not. I think Michael's comment for me, the bit that I'd like to pick up on is the problem of the silos within health and the federal state divide. So state health services are our hospitals, GP services are federally funded normally. And you've all been given a snapshot of our hub service, which is our fixed site clinic in Highgate for people who are currently experiencing homelessness or who have experienced homelessness. And that service needs top-up funding because the Medicare bulk billing rates are not enough for us to sustain the service. And unfortunately, that's fallen in the big gap between state health and the federal government. And we are currently in the last month of full funding for that. Then we've got 2 months of half funding, and then I don't know what. we actually do half our consultations in that service.
Thanks, Andrew. And I think Jonathan wanted to make a reflection, then back to Debra, then I'll open it up to the floor for questions.
Look, the main thing that I see from the perspective of the street side of it is that in doing what we need to do, who do we have to go to? Government. Where are they? What are they doing? What's the misunderstanding in regards to reflecting that all the work, that the good work that you guys need to do has to come from government? We need to present the whole factor to actually get the money. And without the money, the guys and girls are absolutely wasted on the street. But the money's got to come from a pen swipe. Who does the pen swipe? Who are we supposed to go to and see and talk to try and get this really going? Save the lives. Professor Lisa, 2 years ago, came out with 56 deaths a year in WA. 56. I was going to line up 56 pairs of shoes and said, where is everybody? You can't do it. And I've come close, very close, to losing my life living on the streets and afterwards. And I've known many of them. But we need to collaborate together, turn around, bang on doors, and get the money from government to do what you guys really want to do.
Thanks, Jonathan. And we might come back to you after, Suzi, to talk about this new health plan and homeless, because I think that could be an opportunity to turn the acronyms Michael mentioned into something that's whole of government in terms of health. But over to you, Debra. Thank you.
I think we go to the floor, but I think there's something in all of this, you know, and as a service provider, we get fixated on the service, the system, what we're procuring. But in fact, if we focused on actually, to your point, Jonathan, when you were talking, what is the reality of lived experience? What do people need and want? And everything else meets that need. So the starting person is the, you know, the starting point's the person rather than the system.
Thanks, Debra. Oh, so, okay, clap.
No, you don't.
So do we have any questions from the floor? Yes, so I'm Justine Collier, the CEO of Rise. So Sarah, Justine's over there in the white, in the beautiful white top with the pink skirt.
Thank you so much. And I really love Dr. Jim's thing. So thank you from dialing in from Boston so late. Like you said, the humanity coming through, it was amazing. We can get very frustrated from the government perspective, and I wonder if it really is up to us to do what we can control. We tend to get very giddy and excited about the thought of money for a pilot. We can equally say no. And I just wonder if we can help influence the commissioning process more by saying we are not going to invest our time and money and raise the hopes of people with lived experience unless we get a firm commitment at the start about what the shared measure of success is and what the commitment is to fund something, because otherwise it's just another, to Lisa's analogy, it's another headstone in the graveyard, and it's quite traumatizing to keep trying these things. And I think as a sector we could possibly do something a little bit more organized to stick with each other on that. So if Deb, for example, said, I am not going to put my hand up for that pilot because there is no commitment to going anything behind it, I think there's enough people who would stand behind Deb and go, I've got enough faith to say no as well. Is that a possibility? Is that something we could do a bit better?
So any reflection from the panelists on that approach?
Well, I mean, I think there's a place for pilots where we don't have an evidence base, but I actually think I think we have enough, you have enough evidence in homelessness through the years to not have a pilot for a medical respite centre because we know who's being discharged. So I think there is merit. And if I come back to the very early days of how the WA Alliance was formed, it was formed because people just didn't want to keep doing homelessness service provision in the same way that wasn't working. So I think we sometimes underestimate our collective force as individuals who care, as opposed to being service providers, that we can shape some of that.
On a national level, as part of the Alliance, they now have the Australian Health, Housing and Homelessness Network, who can advocate for particularly the health of homeless people and how that intersects with housing. I think we need something similar in Western Australia so that the services are working together to secure the funding for everybody.
Thanks, Andrew. And I just want to pick up that we do have Minister Carey here at 2 o'clock. We're thrilled that the Minister for Housing, Homelessness and Lands will be joining us. So there's an opportunity. The Minister will be doing a presentation at 2, followed by a Q&A. So if you wanted to speak to power, there's your chance at 2 o'clock today. So Jonathan, over to you, and then we'll have another question from the floor.
The only comment I really want to make in all this, and I know from working with a lot of the major parts as far as the sector is concerned, is the communication between the actual organisations themselves and those on the street. It still doesn't work. If you turn around and talk about what you're doing with the systems at the moment, how many of those down in Rockingham, Mandurah, know what the systems are that you're actually running? There's got to be some way to communicate what we're doing and trying to pilot, implement, get going, so that the people on the street understand that something's been done. And it's just not there at the moment. There's a big communication gap.
Thanks, Jonathan. And we've heard through the homelessness strategy the need for those sorts of navigators where people can shepherd people through what can be a complex system. So we've got a Zoom question, then we'll come to the floor. So Sarah, can you ask?
Yeah, thanks. I just wanted to, Michael has just said, thanks, Michelle, yes, for the shout out. Yes, that went well. A full house of 21 people, including a mother with her 8-year-old child. So that's what happened. So thank you again to St. Pat's. Geraldine from Just Home down in Margaret River has asked the question, I'm interested, who has funded the services available in Boston? And she did provide another comment. I was under the impression that without health insurance in America, you did not get treated. And I think Jim has responded, but I'll let you, Jim, respond in person.
Sure, that's such a key question, Geraldine, and kind of an embarrassing one for us because we have arguably the least just healthcare system in the entire world. But interestingly, under President Obama, we had a new healthcare plan, and states are allowed to expand Medicaid. Those states that want to, with lots of support from the federal government. And Massachusetts, a state I live in, decided to do that. So every poor person in Massachusetts, people who make 120% of poverty level or less, have full coverage under Medicaid. So our program is essentially sustained by as doctors and nurses and social workers, we can bill Medicaid for what we're doing. All of the people we're taking care of because they are poor have insurance. That is not the same in other states. So it's a big issue for us across the country why, for example, a state like Texas did not expand. So my colleagues in Texas are not able to reimburse for what they're doing, and it's almost impossible then to sustain the kind of programs we're doing. But you, of course, have a much, much wiser, fairer, and just system of healthcare insurance. And I would guess all things are possible in your world where they are not in ours.
Thanks, Jim. And what a great question from Margaret River. Yeah, thank you, Just Home. Do we have any questions from the floor? Gentleman here.
Thank you. My name is Victor. I'm from Acknowledge Education. So my question goes to, are there any services for migrants who come from on a temporary visa who experience challenges around housing and homelessness? Because the challenges we face is a bit different to the people who have been here. It can be temporary, challenges around navigating the system, or even short-term resources that can help them with information about application. Because over my last 12 years, I've left my country, moved to UK, moved here. I've seen a lot of international students who have gone through mental health issues, but there are no services for them to approach, and even Medicare and all other services, they are not really covered to approach. And then that thing comes with eligibility of services, and how is that being addressed, or is there any services out there we don't know?
Thank you, great question. So would any of the panelists like to respond?
So I think from certainly on the federal agenda and through WACOS and through some other peak bodies, there's been an advocacy around the support needs for people who are migrants who have no status effectively in terms of social support services. And in particular, there's some work being done in the family and domestic violence space because women trying to leave abusive partners have access to no other support. Outside of the multicultural community service teams who provide support in the multicultural space, I don't think we have anyone, John Berger, I'm looking at you, that is dedicated in the space of homelessness and the issue of cultural diversity outside of course, the Aboriginal space. We don't really have any dedicated services. Unless I got that wrong, Michael Pugh online.
But maybe Andrew, in terms of the population of people you see on the streets, is there a large population of people from culturally and linguistically diverse backgrounds?
There is definitely a population of people from culturally and linguistically, diverse backgrounds. What I've found over the years working as a GP is that there are several different systems depending on what visa that you're on, and if you have no status, there's nothing. And I think it's the guys that have no status, and they're often New Zealand citizens who have come to Australia, have worked, paid their taxes, and then things go wrong and they end up homeless and they have no access to Medicare, they have no access to any services that can assist them.
Thanks.
Sorry, the only other comment I'd make is that Gemma Crawford through Curtin University is doing a project through Healthways called Journey Home, and they're trying to sort of understand and map the journey for people with core backgrounds in terms of housing and homelessness, and it's actually showing that that community is very much missing out on services. So, but I guess the one thing that that project will do is we'll start to highlight where are the gaps and then what are the things that we could do.
Thanks, John. And Lisa?
Oh, I was just going to add that my favourite way to do research is actually just to either hang around chatting to people like Jonathan with lived experience or to shadow the services. So I quite often go out with the street health team from Homeless Healthcare. There's often a uniting caseworker there. My dog loves to come. But I guess what I've seen with that is that people don't have to have a Medicare card to be seen by Homeless Healthcare, and certainly some of the times I've been on the street and in the data for street health, there are people who are known to have come from other countries who are really frightened, I guess, about government services. And I think this comes back to the point that Andrew was making about, you know, for Homeless Healthcare and services like that, so much of the work they do is not funded because nothing is funded. Apparently there's a thing with Medicare that you can only get a rebate if you provide your service within 4 walls. So all the kind of outreach work when Andrew actually literally goes out in the street, that's not funded. Seeing people that don't have a Medicare card, that's not funded. And yet these are the most vulnerable of the vulnerable, and they're people who don't even present to hospital, or they present to hospital because they've collapsed and someone takes them there. And that kind of trauma, particularly from their countries of origin, or trauma from being on the street, means that there's a lot of fear about traditional health services and about government health services. And I think what Jim does and what Homeless Healthcare and does here in terms of that outreach work of no judgment, no acceptance, there's many parallels to what people from migrant backgrounds are needing, similar to the street population itself and the overlap between them.
Thanks, Lisa, and thank you for the question. Chelsea from the Community Legal Centres WA, you've got a question? And thank you for standing up so we can find you.
and I used to work together, so we know each other. My name's Chelsea. I'm the CEO at Community Legal WA. We know that people experiencing homelessness have a range of legal problems, and in fact, sometimes those legal problems are part of the cause of their homelessness, such as family violence, loss of employment, loss of tenancy, eviction. Then when people are on the streets or in shelters and other places, their legal problems can expand or continue. We have some examples, such as one of our members, Street Law, doing outreach clinics to homelessness services. But my question for the panel is, should there be more of that? And how can our members work with you to get legal help to the people that need it the most, where they already are?
Any of the panelists like to respond? Jonathan, thanks. And then we might ask Jim if there's that sort of integration in the US.
All right, thank you. Look, I've done a bit of work with the legal service down in Rockingham. Gail, who's the CEO of the Rockingham group down there. But the point with a lot of this that I've got to make note of, we're talking here at the moment about the resurrection of certain particular projects or bits and pieces, or getting this for a project, getting that and doing this. The point with a lot of this is that we are the lived experience. We've actually been there and done it. Why don't you come and ask us? Why don't you come and ask us? It's really, you know, I've spoken to 4 migrants this year who've actually been living on the street and have got major problems as far as what's concerned. If you want to talk about migrants, you come and ask me, and then I'll steer you towards where the people are. As far as any of the questions are concerned, we are very happy to sit down as a lived experience group, form an opinion, or give you our advice, pretty much free of charge. Why can't you come and ask us?
Thanks, Jonathan. Debra, did you want to make a comment?
To Chelsea's comment, I think, you know, Street Law have been doing great work for many years, and I think some of the other legal services are doing more of that outreach into hubs like the Tranby Centre, St Pat's, Ruah Centre, etc. And I think that work needs to continue. And I think from, you know, if I think about the story at Ruah Legal Services, the care and protection service that we started came from women who were experiencing homelessness, who had their children removed, and no representation to try and get those children back. The department has a plethora of lawyers who work on removing children. And so, again, I think listening to the voice of lived experience, what they really needed was someone to walk them through that process across 3 different court jurisdictions. So I think it's probably an area that there needs more resourcing. But I think it's that, again, Chelsea, we were talking earlier, and that integration, that for an hour of legal service, 15 minutes is probably legal. The rest of that time is what are those psychosocial supports that are required that lawyers feel they just can't meet. And referring them onwards, we know, will just be a loss. So having that capacity to meet those needs right there and then as much as we can is a better success outcome than actually referring people.
Thanks, Andrew, and then we'll go to you, Jim, for your reflection on the US.
The one thing that I have learned from working with homeless people is, for want of a better way of describing it, they're pretty disengaged from the system. And if you want to provide any service to them, you have to go out to where they are, where they feel comfortable. Tell your lawyers to come out on Street Health with us. We'd love to have them there to provide advice. When I go out on Street Health, 99% of what I do is just about engagement and 1% is about healthcare. But it's that 1% that can make the big difference as well.
Thanks, Andrew. And Jim, with your work in Boston, is there any integration of the legal side with the health work that you do?
I think there's, yes, the answer to that is yes. And much like what I'm hearing you all say, it seems to be getting more intense and better. For example, in our main clinic, we have the Mass Bar Association, the lawyers think, holding immigration clinics right on site so that people, while they're in the clinic, can have their full legal stuff. The other place that where we're seeing an awful lot of activity, which is really welcomed, is the law schools setting up shop basically in the hospital. So people coming into the hospital for whatever it is have a host of legal issues going on. Most of these are folks who have very marginal housing at best. And they're learning that integration of medicine, or healthcare and legal services is really good. And finally, what I think I've been spending most of my time on is many people, as we're trying to get them into housing after years on the streets, it's the legal system that has to clear the way for them to get rid of their warrants, fix their what we call queries. I don't know if the same word's old in Australia or not, but there's an awful lot of legal issues that have become the roadblock to housing. And if you can overcome that, it makes a big difference. So we now have legal clinics in the shelters where the judges themselves will come and help mitigate queries and overcome warrants. And we're learning that, just like everything else, just what you're saying, the solution to homelessness, sometimes the obstacles require that we all work together in many different facets. And I think Andrew hit the nail on the head when I think of our lives in Boston. As much as I love medicine, I think that's what we're doing. I would say maybe 5% of the time we're doing real healthcare. The rest of the time we're trying to lay the groundwork for working with everybody else who's necessary for this person to get into housing and get healthy.
Thanks, Jim. That's a great reflection and interesting correlation with what Andrew said. So Deborah's got the mic.
So I was just going to make a comment in terms of a real, I suppose, an example of that. So the super ID clinics that we've run as a sector. So for a person who's experiencing homelessness, who's lost their ID, that ID is a passport to housing. And it can take 6 to 8 weeks, if not longer, to get that ID. In 45 minutes, lawyers present, housing present, Department of Communities, Health, that ID is achieved in 45 minutes, what takes 6 to 8 weeks. So that's the difficulty of the system, but that's what an integration of the system can actually do. And I think that's a really clear example of when it works well.
Thanks, Deborah. So do we have any other questions from the floor? No, was that just, you weren't putting your hand up? Okay. Any more questions on Zoom? Okay, so what we might do is, Jonathan, you can respond. I'd like to just ask Suzi a question and then we'll adjourn. So, Jonathan?
Look, the whole aspect as far as the law is concerned, when you're actually on the street, is phenomenal. It actually does carry through with you for years on end. One quick example is tax. Now, when you're on the street, majority of them don't do their tax, and then the taxation office just slaps them with bills. I've seen a guy get off the streets and he's followed through with a $20,000 tax bill because he doesn't know how to deal with it. The whole aspect of being homeless is that your mental health is so run down, you don't know how to deal with things. As I said before, myself coming from university, Royal Australian Navy, the whole lot, during my time on the streets, my mind and mental state was so blocked, I didn't know where to go and what to do. You need to understand, and somebody was talking about the fact that it's not a case of them coming to you, you have to go to them because they don't want to get up and get out of bed or go walking around, or they don't want to be recognised as someone who actually is homeless. There's a major issue to do with this law thing with the women with the babies. They don't register as being homeless because as soon as that happens, it's either the ex that turns around and gets the kids, or who is it? The department, whatever Deb said, they just come and take them. And that's not just a case of a legal battle to defend and help the woman. What department was it? Department of Communities. They'll just come and take them. So why would you register as being homeless if you've got kids? The whole basis of this is absolutely stuffed up. It's not homelessness, it's the system. We need to look at how the system's going, what it's doing, and make the changes accordingly.
Thanks, Jonathan, and thanks for the question, Chelsea. So just before we close, we do have Suzi here from Cato.
Yes, Cato.
So Suzi mentioned the homeless Health Action Plan. Are you in a position to share more about the plan and how the homeless services sector can get engaged in the plan, so we could potentially use that as an instrument of integration?
Yeah, that is the aim. Thanks, Michelle. And not to throw another guideline at a system that already has lots of guidelines, our approach within CAHO is to have a coordinated strategic approach. It's the only way we can do things. We have had the homeless health portfolio within CAHO since 2020, and we are trying to develop an action plan. We are developing an action plan based on some options, lots of options. It was actually when we commissioned Professor Lisa Wood and the cross-agency advisory committee to look at the potential options for the WA health system and what we needed to act on immediately. And so from that work, we've translated it into an action plan, and there's 5 streams that we will be working on across the next 3 years. And the first one is service delivery. We have ongoing relationships with Perth Street Doctor, run by 360 Health Plus Community, and Fremantle Street Doctor, operated by Black Swan Health, and also homeless healthcare with the mobile GP clinics. So they are a comprehensive primary care service that meets people where they're at, fully mobile. Under integration, we're looking at integration of healthcare services, understanding the impact of housing as well, and our stream of stakeholder engagement involves cross-agency and sector collaboration. Workforce development, which I've already spoke a little bit about, and of course data and information, and developing the workforce in terms of the response to homelessness, identification of homelessness, and then the response to homelessness, and also making practices safe and welcoming, also free for specialist homeless healthcare services. So that's the streams that we'll be working on over the next couple of years.
Thanks, Suzi. And is that an internal action plan for the department, or is that a public plan that we can have a look at?
Yeah, it's going to be a public-facing document. It hasn't undergone its final stakeholder consultation, but it will be public-facing. Yeah, so our action plan, it is still an internal document that we'll be working to, fitting in with our operational plan, but it's also going to be public-facing and transparent.
Fantastic. So this, if there are no further questions, we'll bring this fabulous session to a close. So if you could firstly join with me in thanking our panellists. Amazing. Suzi, Jonathan, Debra, Andrew and Lisa. We do have some gifts which the very fabulous Sarah has put there, and because I've got a broken shoulder, I can't do the beautiful, I'm giving them to you. Please, could we have an extra round of applause for Dr. Jim O'Connell from the Boston Health?
Thank you.
Thank you, Jim, for sharing your insights, your humanity, and the way that you approach your work. Really inspiring for all of us here in Perth. Thank you for staying up so late with the time difference. Another round of applause.
And let me just say, oh, I'm sorry. I was going to say, just let me say thank you to all of you. This has been such a shot in the arm to me, and you bring back just the best of memories of all the wonderful stuff going on in Perth. So great to see you all. Thank you for letting me be part of it.
Thank you, Jim. Could you all now indulge me and do a big wave to our Zoom audience so they feel like they're part of it? So hello, Zoom people. Thank you for zooming in and being part of it. So thank you for your attendance. Round of applause for all of you. And I'd now like to invite you to join us for some refreshments and remind you that we do have this. Oh, yes.
Can I just make one little comment, please? Yeah, the voice in the air. It's going to be quick. It's going to be very quick. Look, as far as a lot of this is concerned and what's been done, Shelter WA have been an absolute brilliant platform to get this going. And I've got to say, she's leaving us. She's leaving us. This is her last homeless week. I'm not turning the microphone off. Michelle, from the lived experience, we want to thank you so much for the work that you have done and what you've contributed to. I remember you and I sitting down at a table 5 years ago or something or other in regards to that, and talking about some stuff. This is before you became CEO and leader of Shelter. And the work you've done to promote the lived experience, I have to say sincerely, from the bottom of my heart, thank you so much.
Thanks, Jonathan.
Please give Michelle a round of applause, because she has been an initiator to get the lived experience movement going. Thank you.
Thank you. So great shout out to, I forgot to mention this earlier. So we've got Debra Caparella in there doing an art project. So please join Deb and see whatever she's concocting in there. Please take part in that. And just two little plugs before we leave. Morning tea. We have got some fantastic support from the Sisters of St John of God, and we're setting up the Hear of My Experience Home Project. We've got Elise Haddleton and Trish Owen, who are our project team doing that, and the whole aim of that over the next 3 years is to see how we can establish an independent lived experience advisory council from Shelter, so people with lived experience can really contribute in policy and advocacy work in a really impactful way. So thank you for your kind words, Jonathan. If you're ever in Halls Creek, please come and visit me. And with that, let's go have some morning tea. Thank you all for attending.